What was so wrong with NHIF that we cannot amend?
Okay, you see, cartels are everywhere. Corruption is everywhere. But now we point on NHIF and say NHIF is the most corrupt institution. Now you see, when you want to start something new, you kill it. The SHA law was inconsistent on the basis that it was denying persons from accessing emergency care and any other public services. The constitution says you cannot be denied any public services as long as you're a Kenyan.
Yes.
But someone comes with a condition. If you don't give us your 2.7%, you will not get anything in Kenya. Plus, you don't benefit from the other things that are happening in the country because you're a Kenyan. The government is using the employed people to pull the fund to make the vehicle go. And that's why for the first years of SHA, the driver of the Shif fund will be the employed people only. So the government and the employers have absconded duty. Assuming tomorrow all of us register in, the fund crashes. Yes.
We have 80% unemployed. How do you determine the percentage they are supposed to give? Is it still 2.75?
Now, these ones now, they're on a different regime.
Eh.
They're on the regime of now econometrics, whereby they're saying they're going to do means testing. Means testing is they come assess your household and they say you look like, or based on how you carry yourself or how you're conducting yourself, you look worth this much, and then we'll give you a rate. And that rate, again, the law says you must pay upfront.
Hi everyone, welcome to today's episode of LNS. My name is Lynn Ngugi, and believe it or not, I just came from watching a clip where a member of parliament is admitting that they are also struggling to understand the whole SHA and Shif. And the presenter asked them, but you passed the law, Mheshimiwa? And she said, yeah, I did, but you know we were rushed to passing this bill. And I was like, if these are our members of parliament who are talking like this, if these are the members of parliament who passed something they do not understand, how do they want us to move forward, and why would they expect that we would understand that which they passed that they do not understand? Does that make sense? Today we are about to talk about the whole SHA and Shif thing. A lot of people are saying it's a scam. The government has said no, this is the best way forward. They are committed to providing universal health care for Kenyans as part of their bottom-up agenda. We still have bottom-up, as part of their bottom-up agenda. And with me in studio is someone who has been very vocal, matters healthcare, and he will be walking us through this conversation. But before I let him introduce himself, I just really want to say thank you so much, guys, for really being active participants of our work. I've said our intention with this show is to be able to learn and relearn things that have been taught to us, and also to be able to question things that do not make sense, because we have a collective responsibility as a nation and as a people to make sure that Kenya remains home. In short, Kenya ni home. And also, thank you for subscribing. Remember, subscribing is free, and just by subscribing, it enables our work to reach as many people as possible. Not forgetting, you got us to 1 million subscribers, so asante sana. And now, of course, without further ado, please allow me to let my guest today introduce himself. Hello.
Fine, thanks.
Karibu sana, LNN.
Salama kabisa.
We've been saying Kenya ni home.
Kenya ni home.
Kwako Kenya bado ni home.
Atuhami. Tuko hapa.
We are here. Thank you so much for coming. We appreciate you. Maybe before we get into our conversation, for the people who are tuning in for the very first time, could you please introduce yourself?
Okay, so my name is Dr. Kahura Mundia. I'm a face surgeon, maxillofacial surgeon and reconstruction. That is what I do for the face. That is issues of tumors, cancers, gunshots, anything on the face and neck. I'm also a dentist, I'm a lawyer, I'm a mediator, I'm a unionist, I'm an executive officer at the Kenya Medical Practitioners and Dentists Union, KMPDU. So that's what I do, many things.
Karibu sana again on the show. And as I said in the intro, you've been very vocal, matters healthcare. You know, during times like this when people are really scared of coming out and criticizing what they think is not working, what gives you the strength to keep going?
Well, it's because I know I want the good that everyone is pushing for. And whenever that good, the common good is threatened, we feel like we have to speak up. Because if it gets disrupted, we all tend to suffer. So our aim is to keep on pushing and keep on speaking so that you improve whatever is not working.
Yeah.
So that it works for the best of the many people that we have in the country. We all deserve something that works for us. It's what everyone in whatever country they are in, that is what they're doing.
Yeah.
So
do
journey.
you believe in the awakening that is happening in our country right now?
Yes, it's a good thing that now more Kenyans are able to understand what is happening, how policy works, how politics works, and what their role is in having those directions decided by their voices. Because if they don't participate, they're shortchanged. And if they're shortchanged, they keep on complaining. So we need now to move from complaining to solutions and being part of those solutions. So we have to speak up, model the solutions with our ideas and with our understanding, and get something that works for us as the common good.
And to speak up, we must.
Well, we have to.
Yes.
There's no other choice.
Yeah, we are here because tomorrow something that is very important to each and every one of us will be rolled out. They are calling it Shif and SHA. And I know those terms are a bit confusing to people. SHA, Shif, we understand NHIF. And I want you to be able to break it down for us in a very layman's language. But people are also saying that this whole Shif thing, no, people are also saying that this whole Gachagua impeachment is a distraction so that people don't focus on Shif, they don't focus on Adani, they don't focus on the education, the funds, right? What do you think?
Well, it could be true because both events, or as many events as are happening, they're all major events. And when you have two major events, sometimes is what gets traction. People like more drama, more funny stories that are more entertaining. And sometimes when you're having those many events happening, you can mask out the most important issues. So it could be a political strategy, or it could just be a coincidence that you're having Gachagua being whipped on this side, you're having Adani on this side, you're having Shif running, you're having JKIA. So many events keep on happening. So it could be a distraction. And if you're not keen, you'll follow the wrong rabbit and fail to capture the other antelope.
Yeah, and we have a lot of big things happening in our
all
country.
Major. All
major.
Gachagua is a small matter. Healthcare is a matter for the next many, many years to come, 50 to 100. JKI is even up to 30 years that it can claim. So the incidence of 5-year period of politics, it's a small matter. We should actually focus on the bigger events happening in the country for our children, not just the persons who are about even to retire out of politics. We need to be strategic on our attention. So that's what we should be doing as Kenyans.
Okay, so let's go there. Shif gets rolled out tomorrow, 1st of October. And of course, I want you to break it down for us. But why the urgency? Because we are looking at the registration. They are targeting 50 million Kenyans, but only 2 million, give or take, have registered. And this is something you've said must roll out tomorrow, 1st of October. Why the urgency?
Well, I also don't understand why the urgency. All that I know is that as per the WHO, UN, and the SDG goals, that's SDG 3, the vision to achieve UHC is by 2030 for most countries in the globe. And Kenya wants to be on that map. And that's why they are targeting to have something to present at maybe the next UN meetings and say we have achieved the targets, we've done this. And maybe someone can get an award out of it. And it's a good thing for us to have UHC. UHC should have actually been with us by the year 1963 when we got into independence. And the spirit was actually started by when we had that sessional paper number 10 of 1965, which created the National Hospital Insurance Fund. It was a contributory fund for persons who are employed to make contributions there so that they can be assisted by a public form of public health insurance scheme. Because at that time, we did not have a lot of many private insurance companies. And the government just wanted to cushion most of the Kenyan workers and give them a sense of a public healthcare scheme. And it did work for some time. And over the years, it has grown, it has developed, and they brought in voluntary contributions so that any person, especially if you're not employed, you will come in, make a contribution. It used to be very little money, by the way. I don't know whether it was about 320 shillings those many years ago. And it was a solidarity move, and it was a good thing. And not many people would contribute. Because of that, many persons did not get into it. And again, because they did not collect enough, they could only afford to pay some limited service for some limited services. So they used to pay hospital bed. That's why most people remember NHIF is bed. And that has happened over the last many years, up to about, I think, 1998. There was a reform in the law. And they did some adjustments into it. And it kept on improving over a while. But they were not able to capture most of the many persons who are not employed. So that was a struggle. And in the year 2021, the most recent effective amendments, they decided, okay, now because UHC and SDGs are now coming, let's try and align our laws to the national, through the global laws and what is happening in the global space. So they now reformed the NHIF to now, it used to be National Hospital, now it becomes National Health Insurance Fund. And they did attempt to have it work. That is up to 2022 when Uhuru was doing the Big Four agenda between 2018 and 2022. And all that was wanted was, let's improve, let's have contributions by all persons. Now this time they were even, 2021, they were suggesting both employer and employee to make equal contributions into the fund, to give it more capital, to keep on giving more benefits to the people. Because at least to cushion some of those who are not able to get access to healthcare. And that was the spirit. But now the employers said there was COVID, the economy was hard hit, and they went to court and they blocked all those things. And the employers were let out, and the employees were told, now this is your problem. You're the ones who want healthcare. So for us to rework the math, let's think about it. Let's probably think of how much you could contribute. And that's how one of the conversations of, let's probably give 2.75%. So that was like an actual study that was suggested there. And 2.75 is a rate of, as per the position that we are in, is a rate of the gross amount that we earn as persons who are employed. So it's like a 2.75%. It's like an add of payee. The payee that you get, you add 2.75%. But now this one is earmarked for healthcare. But it's not going to the consolidated fund. It's going out to a particular fund, which in this case, it's being called Shif fund. So that's a 2.75%. It has no caps. So even if you earn up to $1 million, whatever, you'll get 2.75% per month going into that fund, earmarked for particular services. Now, the speed is, I don't know why the speed, because the laws should have had a lot of public participation, do a lot of broadcasts, engage people so that you go together. But not because it was done in such a way that it was, well, some people would say there was adequate time, but in my opinion, from the legal point of view, there was very little time. About 7 to 10 days, actually even 10 is an overestimate, about 7 days was given for each of the laws that was coming up towards this particular program. And this happened last year. And because there was a position of let's announce something during Mashujade. And the laws were assented to, and Mashujade came into effect, and the laws started come the next month of November 22nd of November 2023. And that's how Shif law, the law is Social Health Insurance Act, which seeks now to repeal, seeks now to override the old law, which is the National Health Insurance Fund. Well, it has a good thing, I would say, but now it has been mixed between, there are mixes of things so that it looks sellable. There is what the Constitution provides since the year 2010, and this was the emergency services. All Kenyans, as long as you have Kenyan blood flowing through you, your government has a duty to provide emergency care to you. This ought to have happened from the year 2010. That September of 2010, we should have had a fund set up by Treasury, run either by NHIF of that time or wherever, or under the social protection programs, and provide or assure everyone of the right to access emergency care. This never happened. The Treasury struggled, they say there were no funds, and they just kept quiet. Again, that was moved into the Health Act to be operationalized in a way. But then it still remained as a dream that one day they'll operationalize the emergency fund for Kenyans. Now, away from that, we have what the Constitution also says, the right to healthcare for all Kenyans, as under Article 43. Now, not all Kenyans can afford healthcare, and everyone keeps on to spend out of pocket. You see, in Kenya, you have about, they say from the statistics, about 20% are insured in different ways, either insurance privately, insured by NHIF, or those community groups that persons probably contribute and get to buy healthcare for themselves. So about 20%. So about 80% are not covered. So these 80%, they hustle. So whatever you collect, you have to go and pay to the hospitals. Now remember, since 1963 to date, Kenya was to assure its people of healthcare. But that was not realizable until now, when it became very explicit in the 2010 Constitution. And it is where we are, to operationalize or actualize that Constitution. Either with the structures we've had, that is NHIF, or with whichever structures that will come up. So now why we shifted into social health insurance is because of the court cases. FKE went to court in the year 2022. That time I was telling you about the matching. And the judge at that particular time said that this case is quite important. I cannot decide it alone. I need a 3-judge bench to decide on these matters.
They went to court?
They went
for
FKE,
what?
Federation of Kenya Employers, went to court.
Why?
On the argument that we cannot co-contribute or co-match what you pay. So let's say you'd contribute 500 shillings as an employee, and the employer contributes 500 shillings, that's 1,000 bob. FKE said no, and they went to court to say we cannot match. You see, like in German, employers and employees contribute to these particular funds. So FKE goes to court. The case is argued that we need to have a 3-judge bench, and the matter is referred to the Chief Justice. Now, since 2022, the matter has never moved. It was referred to the Chief Justice, and the Chief Justice sat on the case. And the case still hangs on the internet, on the portal system of the judiciary. Now, because it hung there, the persons who are interested in reforming the NHIF law, they were kind of now stuck. What do we do? We still have an agenda to pursue, and we don't know where to go.
What's this agenda?
The agenda now is to still deliver the reforms in NHIF. And they're like stuck. The case is stuck in court, and they don't know what to do. So they said, let's duplicate and give it a new name. And let that matter die in court and run with another one that looks like the other one.
No way.
That's what happened. It's all in the court systems. The 3-judge bench of 2021 was never appointed. The case of matching of contributions was never decided. It's still under a ruling, directed and advised to the Chief Justice. That's 2022, around September, thereabouts. Now the NHIF law is replicated in total. This is legal engineering now. You put it in another scheme, rework it, and run with it. Now when you run with this one now, you drop that interest, which is the matching contribution. So they will not chase you. That's the FKE people. And now you have the only people to deal with is the employees, and give them the rate. And you actually, word for word, you'll actually see the laws are almost a replica, other than the additions of now the new creative elements, which is the primary health care and the emergency care fund. So emergency care fund now is being given life from the 2010 constitution. And the primary health care fund is a good thing that is being brought. But remember again, in the same constitution of 2010, it says primary health care is supposed to be done by the county governments. And since 2010, the county governments were to deliver on this function. But I don't know. We have a problem either at the county governments or at the national governments. None of them want to work together and deliver this to the Kenyans. So, and there's been issues of county governments are being sent money, they eat. And they don't want to do the project that they're supposed to do, that is roll out primary health care. So that service machinery is yet to happen. So now someone comes as a godfather and says, now I'll guide you. And I'll guide you now. Legally, it's in conflict with the constitution, because primary health care is supposed to be done by the county governments. But the national government says, I'll do it for you. I'll give the capital, which is the 4 billion that has been allocated as per this year. And I will send this money now to you, county governments at levels 1, 2, 3 of hospitals to do what you're supposed to do. But I'll keep the money. So this, and I'll direct and keep it.
Okay, so this primary health care and this emergency and now Shif, they fall under an umbrella.
Under an umbrella.
And this umbrella is now the social. It's the Shi,
which is a social health insurance. The law, because you have to call laws acts, it's called the Social Health Insurance Act.
Okay.
Now in this Social Health Insurance Act, we have SHA, Social Health Authority. It's like a board. You see, the NHIF had a board.
Yes.
National Health Insurance Fund Board. These are just names. It's semantics. So now you call it authority. It's a group of people sitting in a board, about 9 people, made from either the employees now, the employers now are left out. A group of the government officials, representatives, and the interested persons. We have persons from KOTU, and they form the 9-member persons of the board of the SHA. So board and SHA and authority, they are all synonymous. Yes. Now, that is like the head that controls how this law operates. This law has 3 legs. The one leg is the primary health care. The other leg is the emergency care. And then there is a contributory fund, whereby now employees contribute or are going to contribute the 2.75% of the gross.
Now the Shif.
The Shif now, the Shif fund. Remember, in countries like Rwanda, it's a rate of basic pay. There's a difference between basic pay and gross pay. Now, basic pay is a smaller portion of the gross pay. So ours is more like that. They're taking too much because it's a bigger cut of the rates that you have. Then there is no caps. Countries like Germany, you have a cap. Persons who are probably high earners, they get a cap that you contribute maybe up to 10,000. After that, you are exempt from the system, and you have to prove to the system that you have a cover that is working for you. So you're let out. But for now, they say all of us Kenyans will be in this particular fund, and we must contribute to the fund. Now, the laws are inconsistent. Now, a lot has happened actually this year, not even last year, because the law came in November 2023. In November, there was a court case by the union and some of the civil society persons. And the issue now here was the unconstitutionality of that social health insurance law. And that matter was given an order, interlocutory order, that's an order before the full completion of the hearing of the case. And remember that time, one Sunday, the president said the judiciary was captured, judges are corrupt, they're giving orders, they don't want us to progress, it's not right, we'll look for those judges and we'll teach them a lesson. Remember that? That was a particular Sunday. So that was like ground preparation of what was to happen on the next Monday. The next Monday, there was supposed to be a ruling because of the court order that was given to block the progression of She. So the judges at that particular time were like in a confusion. The president of the Court of Appeal is like, okay, what do I do now here? So the matter came on for the first hearing, and it could not progress because the judges were not aware of what was happening. They had just been caught by surprise. So they gave us another date. On the subsequent date, they did agree that either the interlocutory orders were given too fast, but they did agree that the SHA law was inconsistent on the basis that it was denying persons from accessing emergency care and any other public services. So if you wanted an ID, or if you wanted to go maybe renew your driving license plates, or probably you wanted a renewal of a passport or something, you will be denied that on the basis that you're not registered into Shif. Remember, there are 3 vehicles.
Wait, what?
There is primary healthcare.
Yes.
Shif
and emergency.
And emergency. They're all now fused with the condition you must join Shif. If you don't join Shif, you don't benefit from the other 2.
So wait.
Plus, you don't benefit from the other things that are happening in the country because you're a Kenyan.
So
that was the inconsistent part of the law.
Mm-hmm.
The condition was you must be a Kenyan. They see the constitution says you cannot be denied any public services as long as you're a Kenyan.
Yes.
But someone comes with a condition. If you don't give us your 2.7%, you will not get anything in Kenya. You just exist. So that's why the civil society space went to court, one for reasons of inadequate public participation, and the inconsistent clauses that breach the constitution. So that's why we went to court. And in January 29th of 2024, this year, the Court of Appeal agreed that those sections were inconsistent and would remain suspended as long as the law was still being heard in the High Court. You see, from the High Court, we go to the Court of Appeal. So that was the position. And that is when the case went to be heard in the High Court. And it got heard all the way now to July 12th of 2024. When the High Court said the laws, all of them, they were hurriedly done and there was no adequate public participation. Remember, the public participation will happen at Turkana and at Makueni. And not many people would go there. And even on those particular sittings, it's on record that not much happened. So the laws did go in, get signed, assented on, without many Kenyans knowing what was going on. We tried to speak up, but the traction and the education, had not reached a point whereby we wanted to know what is happening in the country. Mm-hmm. So the laws have been declared unconstitutional. And now, again, the SHA authority, as directed by the CS Minister, the CS of Ministry of Health at that particular time, decides we need to go again and appeal. See, they were told, we are not going to kill the laws permanently. See, in a country that is progressive, sometimes you give a chance to redeem yourself. They were told, I want you to redeem yourself. I'm going to give you 120 days. Either do public participation to make people know about these laws, and before then, you come report to me after 120 days. So this was to happen until November of this year. So this did not happen now. They cited that the parliament is too busy. There's a lot is happening. We cannot restart the laws. no, we're going to do it as we had decided. So they filed another appeal now. Remember, the first appeal was filed in January.
Yes.
There's another appeal now that is filed now in September. And now this other appeal, the laws are suspended by 45 days. Sometimes when you go to the judges, you can tell them, I've heard you, but please allow me some time to just reorganize myself. And they were given 45 days. So this is 45 days, either within the 120 days or 45 days plus the 120 days. So it becomes like 165 days. But they did nothing about this. So as usual, they went to the High Court and to the Court of Appeal. And in Kenya, it's a very interesting country. You have so many judges, but not all of them, being a judge, you're like, not all of them think alike. And sometimes based on subjectivity, everyone decides on their interest or the way they understand things. Now, this particular section of the Court of Appeal, they decided that the laws are somehow important. And the matter is very, very important. They said so. But it has been declared unconstitutional. But again, it is important for the country. And when a law is decided unconstitutional, we go back to the status ante. So you actually go back to the NHIF law. But then again, I want to give a date to fast track these cases. And for this reason, I'm going now to suspend the ruling, the judgment of the High Court. Suspend it so that we can hear you in urgency
and move forward,
pending whatever. But now the problem is this. That's a very big green light. Because money now is going to be spent. And if you spend money on something that is quarrelsome, that not everyone is clear about it, you're going to burn money. And if the outcome is going to be flawed, that means you'll have lost that money. Now, the Court of Appeal ought to have maintained a status quo. Don't spend, don't do anything, pending the fast tracking of this Court of Appeal case, so that we can have a clear and final position, that you can move prudently, as is expected of the use of public resources. You don't just give a green light for the use of public resources like that. You have to measure the effect of your actions. Again, remember now this September Court of Appeal ruling is inconsistent with the January Court of Appeal ruling. The January one, from the Court of Appeal, same court, same president, but different judges, 3 different benches, ruling differently. The others said, the fact that you deny people emergency care, and the fact that you deny people the right to access public services, that is unorderly, that is unconstitutional, that should actually, we agree with the High Court. But now this September court bench, they don't even remember that. So that means as you're speaking today, the law, you see the law, lawyers use words, and the words are written in script, and now they're printed, and that becomes the law. It's still as it was. It has not been amended. Unless now we move forward to amend it. But as for now, if you're not in the Shif, you will not get emergency. You will not get primary care fund benefit. You will not get anything if you're not in. Plus, I don't know whether they'll actualize the aspects of now when you're going to renew your driving license, renew your permits, whatever, whether it will still be allowed or they'll say, it was just language, we will ignore that section and continue. So those 2 points are inconsistent. See, in the law, you have to be very keen on what you want. So now, SHA has a green light. And that's when you see now this September, this October, they're now braver. They're coming out. Now they're doing now post-enactment public participation.
So they was already doing it at the back.
They never did much last year.
Not the public participation, but they continued.
They continued to do the tariffs.
Yes.
And they continued to make the laws.
And the tenders.
And they really prayed hard. I don't know how they prayed hard. You see, everyone has their own prayers. You pray to your God, and everyone prays to their God. And the prayers were hard, and they got the green light. And now that is where they're rolling out. Now, the rollout comes now with the system to be developed, to have persons register in, and to have persons now being told you have to contribute into this fund. That's for the employed persons. Now, the other persons who are not formally employed, see now they don't contribute. They don't even know what, okay, they have to join in, as it is stated, for them to benefit on primary health care and to benefit on emergency care. But they don't contribute. Now, what happens now? This now becomes now business. You have a few people. See, in Kenya, we have, I don't know, I think about less than 20% employed.
Yes.
Formally employed.
In the system.
In the system. Now, these are persons who are assured you'll get something from them. Versus the number of Kenyans in the country, that's 80% of Kenyans unemployed or in the informal sector, plus the OVCs, that's orphans, vulnerable persons, and any other persons vulnerable. You find now that the amount collected from the employed people is very little. And it cannot carry the whole country. Now, if it cannot carry the whole country, you try and think, what benefits can I give? And how they give benefits, the benefit tariff. The benefit tariffs become inadequate because they project inadequate funds collection. So that means you as an employed person, if you contribute that 6,000 per month, that is 72,000 per year. You'll be told you probably access this and this and this and that, but to these small limits. Now, the aspect of this limit being too small, you will not find satisfaction with what you bought. You see, there is value for money. So you go buy a full bread at 50 shillings.
There's no incentive.
Yes. And then you're paying the 50 shillings, but you're getting half a loaf of bread. But you feel now my 50 shillings can buy me a bigger bread elsewhere. So that conflict of persons who are employed is what is driving this, because we don't understand why, as persons who are employed, why you should pay this much, get this little. That incongruency. That means now if it's not enough, I'll have to go back into my pocket and buy elsewhere a supplementary cover to help me cover myself.
Yes.
You see, healthcare is very interesting. If you don't cover yourself, one day you're struck out and you have to spend too much you didn't have. But if you have insured your risk, the cover comes in to cover for your risk. Now, this is an advantage for the formally employed. Now, for the informally employed, for the informal persons or the persons without jobs, the government has a duty. Duty duty to use the general taxes. We all pay PAYE, we all pay VAT,
Yes.
we all pay excise duties. We pay so many forms of taxes and levies. And these monies go to the consolidated fund. And it is now from the consolidated fund they give. They prayed for 50 billion. They were given 4.1 for primary health care. And about, I think, 2 for the emergency care fund. Now, this is too little versus the number of persons in the country. Too little, in that the informal employed persons cannot benefit optimally. That means, again, they'll also be affected by the same system because they'll go to the hospital and probably the amounts allowable for use and spend are not adequate. Then we'll start running short of drugs. We start running short of many things that are happening in the system. We start complaining.
Let me ask there. Sorry, guys. Today I needed my pen and paper. For the 2.75, this is for the ones that are employed, no cap, right?
Yes.
We have 80% unemployed. How do you determine the percentage they are supposed to give? Is it still 2.75?
Now, these ones now, they're on a different regime.
Eh.
They're on the regime of now econometrics, whereby they're saying they're going to do means testing.
They are going to do what?
Means testing.
Okay.
Means testing is they come assess your household and they say you look like, or based on how you carry yourself or how you're conducting yourself, you look worth this much. And they say this is a household. So everyone belongs to a household, everyone who is an adult. And they say because you're over 25, you're a household,
Yes.
you have to pay a rate. We'll assess based on the forms that you fill, and then we'll give you a rate. And that rate, again, the law says you must pay upfront. For the formally employed, they pay monthly. For the informally employed, the law as it is right now, unless it's changed, it says upfront, you must pay whatever you're assessed. It's like you go get graded, you're told you look like you'll pay 20,000.
Let's use an example. We have a mama mboga here. So they come and assess a mama mboga and they say, it's like you earn 200 per day profit.
So you calculate that,
Yes.
and then you'll give a rate of 2.75%.
So they'll give you a rate of 2.7.
Yes. But the minimum threshold for everyone, if your business is so funny or if your economic setup is not that well, the minimum you contribute is a base of 300.
So if my business fails, I can no longer. Why are they
No.
operating under the assumption
that you have an income?
I have an income.
That's a hard part, because not everyone has an income. And those who don't have an income, they're supposed to be cushioned by general taxes. General taxes either in the primary healthcare fund, directed there, and again advised by the county governments to roll that function, or under the emergency in case of anything, you could benefit from the emergency care fund. But if you don't have, you don't have. So that means either the system will lock you out because you don't have, you don't have. And that means you're either supposed to be registered by the CHPs, to be enrolled into a program, and your money to be allocated for you to benefit. So you see, one time, I think in 2019, they said they had about 13 million households in the country, about 12.2 million thereabouts. And each household is supposed to have about 4 persons to about 5 persons. Now, when you compare 5 persons in a household and the amount of contribution put in there, the ones who are formally employed, they will contribute because the law is as such. But the 5 of them or the 4 of them in that house, if they find that the benefits are not commensurate with whatever they have been contributing, they will start complaining. And if they start complaining, they'll have nowhere to go other than to buy out of pocket another cover.
A private one.
Yes, a private cover. Now, the informal persons, or the persons who are not insured, they are also affected in a different way. So it's a mix of many things happening. There are also like 4 in the household. Name them, they're like now loaders. Let's call them like persons who are coming into the system. They have to benefit from the system, but they don't contribute. And the system is not well optimized or funded. That means the system doesn't pick up. So it will take really long when you assess the business, like the NHIF, SHA, and the whole matrix. You assess it like you'll take too long to collect enough money from the people for you to give the benefits that you would want. So that's why you have these conversations of, could it have been better probably to rework the math? Either cap so that you can secure the formally employed to at least have some sense of stability. And then for the ones who are really exposed, optimize the funds. Give adequate, like each head or each person allocate something towards that particular fund. And assure Kenyans of UHC. See, universal healthcare coverage is a good principle because worldwide we all know healthcare is very expensive and it's always dynamic. And not many people, like in our sector, low middle income country, we are able to afford healthcare. But we pay other forms of taxes. We buy sodas, we buy bread, we buy petrol,
Unga.
we buy credit, unga. All these things, there is a tax. But that tax goes to roads, pockets, trips abroad, to other things. Yes.
Pockets.
So the prioritization of healthcare, just like you see, you have about 650, I don't know whether it was 650 or 600 billion given to education sector. In healthcare, they give a very little amount. They give about 127 to the Ministry of Health. And counties now get their monies grouped up and sent. This year they say they got 370 or 380 billion. Now, out of 380 billion, how much is supposed to go to the people and to the service delivery? That is primary healthcare. That needs to be, each issue needs to be given money clearly. And it's supposed to be ring-fenced at all. This money goes to HR, resources, the staff, and this one goes to drugs, this one goes to maintenance of facilities, this one goes to health promotion. And every amount or each vote is ring-fenced. Okay. Then it works. That doesn't happen. Counties are just told, take your money, as per your projects, go. The ministry gets 127 as of this year. All right. So this is below what one time in the year, I think 2001, was decided as an Abuja declaration. About 15% of our budget should go to healthcare. So if our budget is that 2.6 trillion or that 4 trillion, 15% ideally, on the ideal state, should go to healthcare. Either from both levels of the government and then into the many fragments that it want to, but that should be at least a budget. Period. And that was an aspiration position that maybe that amount as suggested, it could be 15 or more, but very less as we do will not work. Because in Kenya, we usually range between 4 and 6, 4% to 6% of the whole aggregate of contributions for the taxes. That means the government has a good spirit, but the government is shooting itself by underinvesting in the sector. And now we have a situation of overselling or mis-selling. You keep selling so much hope and selling people, we will do this, this is good for you, this is good for you. But you're not doing it yourself as a driver so that you actualize that for the people. So the truth is, people get in, then they get frustrated, which is not okay. So that frustration is not what should happen, because how healthcare operates, you see, you'll attend primary healthcare. Your case now will go into Shif. How it goes into Shif is because in healthcare, you have like a chain. You have a cough, you go to a nurse. They tell you your cough is this small, but I think you'll probably need an X-ray. And then we'll send you to go to a physician at the next level. You're either starting at level 1 dispensary, go to level 2. Level 1 is community, then go to level 2 dispensary or community clinic, and then go to level 3. And if your case is still not handleable, you go to the level 4 and 5 and 6 as you complicate. Now, as you go along the chain, you need persons who understand how to manage your case. So remember, Shif covers for levels 4 and 5 and 6. Shif covers for level 4, 5, 6.
So who covers for level 1, 2, 3,
1,
and
2,
4?
3 is PHC.
1, 2, 3?
1, 2, 3
Yes.
is PHC. And then emergency care fund is in case of any emergencies, you get into the system and you'll be billed on that particular area.
Okay.
So if your case is too expensive and you have not contributed and you're supposed to go out levels 4, 5, or 6, and there is not enough money in the Shif fund, that means the Shif fund will start bleeding. It starts becoming unsustainable, like what has happened in Ghana. The dream is there. It's supposed to work. But over time you get, now this is they're selling. And if we all get excited to join in and there's not enough funds, the fund will start bleeding. It becomes again unsustainable. The fund starts to fail. We start complaining that Shif came, or Sha came, she came, but it's not helping. So the good point to start with is to operationalize all these funds with adequate money and protect everyone. All interests must be protected and balanced. The informal people, care for them because they are your people. You are the government.
And they are 80%.
And they're about 80%. And because of your other policies, you have affected them. They're not able to self-employ or even employ many. See, all these things eat each other. If you have good policies, you'll have a very reduced informal sector because persons are able to generate revenue, they're able not to even purchase income, to purchase insurance, and they're able to cover themselves. But because of how we've been going or how the economy is evolving to be, not many people are able to make a living. And that lack of making a living keeps them in jeopardy and they don't get to have their health cushioned. So that creates a dilemma. So many things have to happen in the space for things to work the right way. Now, surprising, most people we are all observant of what has been given as the tariffs. We have, the tariffs were gazetted the other day on 20th September. And it's sad that there are limits to each. And if the limits are not adequate, you know what is going to happen? You can tell what's going to happen when the limits are not adequate. If you're told to go and see a dentist, let's say you have a toothache. Now, a toothache cannot be solved at levels 1, 2, 3. Reason being there is no dentist at level 1, 2, 3. And if there are, there could be persons who are like assistants to dentists who will probably manage your pain as emergency care responders at that particular time or first responders and then refer you to the dentist at levels 4, 5, or 6. Now you'll come and your cover will say, for now, as you speak today, for now, it says there's no money for dental coverage.
But we are rolling it out tomorrow.
Yes, and the money will come based on availability of funds. That's when we will assure you. You see, I can promise you, but I give a condition. I'll give you 2,000 bob for dental when I get funds. That's the language that is in the law. When I get funds. When? I don't know whether it's tomorrow.
Yes.
Or after 4 years, or after 2 years. I don't know. No one knows. But the promise is when we collect enough, we will tell you. So when will the enough be collected? So if it takes too long, you'll probably never have that dental benefit. So that means when you go to level 4, 5, 6, you'll have to pay.
From my pocket?
Yes, because it's not there. You are told it is there. Join in.
But then I'll go there. They'll tell me it's not there.
It wasn't there.
So I either deal with my pain, and they can't treat me.
Yes, because now the system locks you out based on what it says. Because a level 4 facility at the counties will want to offer the services. But they know if they offer, they will not be paid. So because there is no one assuring of reimbursement.
So while we are at it, is it true there is a limit to how many times you can go to the hospital?
See, the limit will be on an exhaustion. If I give you 2,000 bob
for my dental
or for anything, if you exhaust it,
ideally,
how will you come back?
There is no money.
You ate it. So if you ate it or it was consumed in your last instance.
Oh goodness!
You see, I'm giving dental is a little bit tricky.
Yeah,
let's go like hypertension.
Let's do a general one.
Like hypertension cases, they're giving the limit of the visits at I think 28.50 or thereabouts. So if you spend that, it's done. So that means
I have to tell my body
visits and the drugs and all that. You see, there is even no pharmacy package. They removed it. As they were starting, they tried to do many things good. But because of lack of funds, they pulled out some things. And now they're like, there is no pharmacy package. Pharmacy package is now where you'll get like assured of drugs at different levels of facilities. But now, because if it's not there and you're not assured of anything, the dilemma of where do you get supplementary drugs when you're given for a particular condition. So you are selling, but if you missell, you overpromise, and then persons get disgruntled. Now, if it is UH you want, which most countries want, which most countries are also following.
The universal health
yes. Care. Inject, like do it intentionally. Give that 50 billion to PHC. Give that 50 billion to emergency care fund. Give caps to the employed people so that at least they can have some benefit to supplement in case of any emergencies and cover for other things.
Doctor, let me ask you. So, given that, for example, I'm in employment, why is this mandatory for me where else I can get a private cover? Because I'm thinking maybe for 60K per year, a private cover will give you greater benefits.
Well, you see, private covers, they also have to sell.
And where does this leave the private covers?
It's an evolving space. So the private insurance are like watchful. They're like, okay. Now, for them to be on board, NHIF said will be the first payer. Will be the first payer. No, this is not NHIF. Shisha said will be the first payer, like the first charge. When you go to the hospital, we'll pay the first bills. The top-ups, the insurance will pay.
Yeah.
Now, the insurance people are now supposed to rework their products and price them differently in a way that they're attractive to the people. So now, when you want to supplement, it goes in. But now when the demand goes higher and you want more profits, because private people are driven differently, they'll still keep their premiums where they are or keep them up because the demand keeps on, it's too much. But in Kenya, we've not had a situation whereby you have a lot of many persons purchasing private cover. About, I think 5% or thereabouts have private insurance covers. Most people are on NHIF. The insurance we have in Kenya, most people are in NHIF. And maybe it's now to be she. So this means that we really have to optimize whatever we are working at. If you missell, you're not doing truthful things to the people. And you're collecting money and frustrating them in the long run. And then now we'll learn again, like we did in NHIF for the last 50 years. See, when you learn lessons, you don't forget them.
Yes.
Now we are restarting again because we should forget the lessons we built up. But the promise is we learned and we've carried the lessons from NHIF to SHE, and now let's move forward. But in the principles of understanding insurance in healthcare, the lessons are still too many. And will probably be where we want that UHC optimally, I don't know, maybe in the next 30 years, that's where we will be.
Okay. So
if the government does not tomorrow, next year, allocate funds into this.
Let's talk about NHIF because something caught my attention. When the rollout happens tomorrow, the funds collected will be credited to NHIF until for this month, right? Will be credited to NHIF. But the reason we are running away from NHIF is because NHIF is corrupt. We cannot trust this system, but we are still crediting funds in the system amid the rollout, okay? So my question is, number one, what was so wrong with NHIF that we cannot amend, that we have to come to a new insurance? What was so wrong that we couldn't possibly amend?
Okay, you see, cartels are everywhere. Corruption is everywhere. It's like corruption flows everywhere. From the roads, you go meet the police. You go another corner, you go meet someone else. So you go get an idea or an abstract anywhere. Everyone wants something from you. So, but now we point on NHIF and say NHIF is the most corrupt institution. Now you see, when you want to start something new, you kill it. Now if you want to start a new Kenya, we kill the old Kenya.
It's corrupt.
Yes, kill the old Kenya, start a new country. That should be the ideal. Like break the regimes, how it has been, form of governance, and start anew. That is a spirit to reform. Sometimes that may be too difficult and you work from inside. And that's why in 2021, they started the amendments of NHIF to rename from hospital to health. You see, hospital was a name, Hospital Insurance Fund. Now this is Health Insurance Fund, which was a good thing. Now, for a long time, it was still social because we're all contributing, we're all trying to cover each other. There are voluntary aspects, but voluntary now you cannot beat people to join in. That's why you have to make it mandatory. Mandatory was for the employed. Voluntary was for the informal sector. That was the spirit. So they tried to amend those things in 2021. And like I've told you, FKE at that particular time, see, employers don't want to carry the burden of the employees. And they say, it is your burden, carry it alone.
Figure it out.
Now, that's why they went to court, blocked the court case, and the court case was referred to the 3-judge bench, and the CJ sat on the case, either by accident or by intention. Now, if it was by accident, it's okay. If it's by intention, then it gave room now to the developers of these reforms to consider to restart something new. And that's why now N was shifted to S, became Shif or NHIF now. It became the Social Health Insurance Act. But the spirit is still the same in a way, other than the inconsistencies of denying and clashes of the right to emergency care access, the denial of public services access, and the fact that many people in the informal sector cannot contribute. And because they cannot contribute, the government is shy to give them money to assure them of healthcare. The government is using the employed people to pull the fund to make the vehicle go. It's like you're using someone else's money to fuel your car, yet the trip is yours. You want to go to Mombasa. Use your money, fuel your car, go to Mombasa. Don't use another person and tell them because you are in this state, you will be the one to fuel and we go. It's being a little bit crafty. And that's why for the first years of SHA, the driver of the Shif fund will be the employers, the employed people. Only, not even the employees. So the government and the employers have absconded duty. See, in German, employers have a duty to you as an employee to at least assure you of something. It's like give me, I give you. I give you my labor, you give me something in return, which is the health insurance. That's why insurance, healthcare is usually most of a part of the employment contracts. That as your employer, I'll give you something. As much as I give you salary, I give you housing allowance, I give you commuter, I give you communication allowance, I give you health insurance. It's something good to give. Now here, the situation is different. Our employers say, no, carry your burdens, go. Since we are observers, COVID hit us hard. But everyone felt COVID. No one did not feel COVID. So you cannot say just because you are an employer, you are exempt. And the government says, because you don't collect as much, we also don't care. But the employed people carry this burden, move with it, go, and do whatever you're supposed to do. So those are the frustrations that are ready to happen in that system. That the employed will be overburdened. They have been overpromised. They will not get enough. It will not work. See? And if for it to work, you need to put in money, either from the employers or from the government, so that all of us can enjoy the common good. So that common good is not yet to be realized, as long as you're all shy to do the right thing.
So can you tell me one good thing Shif is going to do that NHIF did not do?
Well, the only new thing...
Good.
The only good thing would be, let's say, the aspect of now they have operationalized the emergency fund. Because for the last 14 years, the Treasury was told to allocate money to that fund. They never wanted to create the fund. Or they just say there were no structures or legal frameworks to guide where to put the money to.
Yes.
Now the money has been put. But now that good is coming with a condition. You must join the fund on the other side for you to get this other one. So you're supposed to enjoy emergency care as long as you're a Kenyan and you have an ID. That should be the only condition.
Is this legal?
See, it's a constitution. The constitution says everyone has a right to emergency care. Article 43(2).
Not the right, the mandatory. You know,
the mandatory part
is it
now,
legal that this is mandatory?
It's a little tricky. I would say it's not legal, illegal. So
it's not legal, illegal.
Like the government says, by the constitution. See, the constitution is a big law.
Yes.
Says you all must get unconditionally. Then someone comes and says, for you to get,
you must
give me 2.75 for you to get 2.75% of your household. And if you don't have, either register with the social programs and then we cover for you. But now those social programs are not adequately resourced. So That means most people will not get. And if they come in, all of them, assuming tomorrow, all of us register in, the fund crashes.
So we are saying Shif has cartels written all over it.
Now, on the issue of cartels, that's a different game. Cartels now come to exploit and enjoy benefits from the system, just like they were in NHIF. They will follow. The owners of the hospitals have not gone away. They are still the same people who are going to register here.
So nothing is changing. We are just replacing N and S.
It could look like so, because hospitals have not rebranded. The ownership of the hospitals have not changed.
Well,
so you've shifted from there, you've brought them here. But here now you're saying, I have a system, this system that's being built for 10 years at 104 billion. They say now they'll recruit, they join in, again, they empanel the providers, the hospitals, the doctors and all that. And now they wait to provide services. So,
but what was me? I'm still not getting, because this is not a system error. It's a human error. No, it's a system error, right? So what was so wrong with correcting the system error in NHIF instead of coming up with another system, the integrated system that is going to cost the country 104 billion? Kwani iya NHIF hatunge correct na pesa kidogo kushinda hiyo ya 104 billion?
NHIF, when it was NHIF, and as the last regime was working on UHC, you see, it's like a baton handover. I'm the president, UHC is in the UN programs. I've changed presidency. The next presidency also has to have a healthcare program. So the spirit is the same. That time they spent like 5 billion to develop another system to deliver UHC.
Only 5 billion?
Yes, that was in the last regime. Now they say, no, we really have a bigger dream. And you want to connect all facilities, all chemists, all KEMSA, everything that is in the country that is healthcare, connect it.
We need to trace also.
They say they want to connect it. And for that, we need to have a system, a very robust system. And they say this system is to be housed under the Digital Health Authority. Remember, there was another law that's called Digital Health. Now, here we have the Digital Health Authority. They say we'll procure the system, we'll give the infrastructure for this issue. And then the other users can come and benefit. That is SHA and whatever, and everyone who wants to utilize something from the pool. Now they're like, they don't have money. Let's approach someone to do it for us. And in their wisdom, they say Safaricom can do, because it provides internet and connectivity, and we need internet and connectivity.
Yes.
And Safaricom is bigger than Airtel or wherever. And we still need some other players, probably persons to, let's call them venture capitalists or angel investors. And here comes, you have Apero coming in, and they have Convergence coming in. And they say they have money to operationalize the system.
Good.
And how they just got lucky and they became to have that trinity is by luck.
By what?
Safaricom, so you could say Safaricom is the biggest internet provider, you'd say. The other two, they are lucky persons. They just come in and they get given and they're told, now you, the three of you, go forth and deliver the system of health people. And it's single sourced, because sometimes you have loopholes in law. They say it's too important, there's no one else can do like this. But Convergence has never done like this. Apero has never done like this. Safaricom has never done like this.
Good.
But you merge them and give them the spirit, go and deliver.
We believe in you.
Yeah, but now remember, this is a different issue. This is not, this is now issues of tenders and corruption and all that. So that's different now. So they say they're going to do a system. I have heard the other day that it's actually an open source enterprise resource program. See, open source is like you have software codes on the internet and you sit and tweak as per your users. It's like free code, like to the IT person, the programmers. And this is now what they're prorating to charge. It's like rent for 10 years at about 10 billion. They have like an initial capital base of about 34, and the rest will be paid for the 10 years as we use that system. So you'll be paying rent to the three owners of this system.
Safaricom, Apero
and Convergence and their owners. So that rent will be paid for 10 years. So they have already secured their interest for 10 years. So they're happy. Then they have eaten their portion as entrepreneurs. They're content. Now this system is now to be used by the players in the healthcare space. Now if the players in the healthcare space get to complain, the owners will maintain the system, and that should be the spirit. So now the value for money, if the system is being procured at that cost, while we know, like they say, it is an open source programming code, it should not cost that much. It should be cheaper. Now, why the other system was being abandoned is because they say it was not well connected, it was not well diverse. The other day we had Safaricom wanting to beat Starlink. Now they want partnership with Starlink because they say Starlink can reach with satellites where there is no internet. So let's partner. So Starlink is here to stay, to provide internet in those places that they don't have. So Safaricom can provide internet
To
and
places they've
appear
been
on other
provided.
people, get programmers, code, do the different modules, and have a system that distributes drugs, providers, hospitals, payment modules, and connects all users into one community.
Yeah.
And they play in there.
And
That's now like systems management and all that.
that's their vision, and it's good to connect. But
Yes.
let's go back to the three key players. Safaricom, we know, of course, the government is the major shareholder in that company. Apero, and the other one, what do we know? And also, why are we giving tenders to companies that were just registered the other day?
Well, this is a special tender, they say. It's like they call it special purpose something program under the Public Procurement Act, and they have to seek an exemption from the CS Treasury. And the CS Treasury is told, this is good, and we want your signature here for us to go with it.
Wow.
And the signature was given.
To people who have never done this before.
Well, I don't know. I've not come across programs or systems done by these people.
I can tell you for free, there is none.
Well, they're registered here
Yes.
as either local companies.
Yeah.
Because they have to have a footprint here and they have to have owners.
It's a requirement.
But there are persons behind. And then there are programmers all over the world. You can pick programmers from India, you can pick programmers from Germany, you can pick programmers from Kenya, from South Africa, and tell them, I want you to program a payment module, which picks a claim, validates a claim, and gets a claim paid. And you, I want you to program something, a module that maps all the community health providers. You program something that brings in the drug people, the pharmacists and chemists. You program the clinics and hospitals. And then have these modules feed into a database. Then have system checks and balances that works. Well, to IT people, I don't know whether intellectual property is that expensive, but not to belittle the programmers, sometimes we overprice our programs and all that. Again, there's another question of who owns this system. Is it Kenya? Or is it these people?
Which part? Because
let
me just break it. No, allow me to break it for you. For example, Apero, I was checking on the ownership. The ownership has two Indians, but then there's a particular Rufus Marundu Maina who has been registered as the director, but he has no shares.
Well,
so you have a company that has people who are not Kenyans, but of course the director is Kenyan, but then the director has no shares in the company. The same thing with the other company. Safaricom ni sawa. Tunajua Safaricom kidogo hapa na pale. So what I'm failing to understand is how justifiable were these tenders? Because 104 billion is not child play. This is a lot of money we are talking about.
I do agree. So in Kenya, we have a good system where actually all countries, you can be able to check public companies and private companies' ownership. You just log into that system, eCitizen BRS, and check who owns what and what shares. Now, these being foreign companies, they have to have a local presence or a local shareholding or a local director or a company secretary. So you have to have a Kenyan. So if they're not investors, you don't give them shares. If they're investors, you give them shares and work with them. Then you can have a local presence. And now with local presence, you can do business in Kenya. So that's what the requirement of foreign companies settling in Kenya. So why particular persons were picked and fronted? No one knows. We have interested persons driving the SHE agenda, driving the UHC agenda, being the same persons, being co-owners or correlated to these people. So there's a lot of mix mash. Either they are lucky people, I'd say. Let's call it luck. That I'm related to you. I'm the one crafting or advising the presidency, and you as my relative or something, or affiliation, you get to know about this. And you're picked and you become a director in there. So you become a little fuzzy. Why you and why not another person? Why it is someone related to them is because you want to have a control and a return to that investment. So that conflict of interest is here to stay. And the same conflict of interest that will still roll out from what we were running away from, the NHIF. So until we become a society that is keen on removing the conflict of interest in the space, we are still here to struggle with whatever we have. So the little that will be collected, you see, DHA does not make money. That's the Digital Health Authority. It's a SHA that is supposed to make money. So I don't know now whether the DHA will be having money from the treasury to pay rent on the use of the system, or they'll say, no, we are not the owners of this system, we are just a store. You see, a store is like a database. But the users should pay something. Users are the hospitals, the providers, and the SHA authority. Either they pay rent to DHA, and DHA gives that money to the Safaricom, Apero, and the other one. Well, it is the truth, it is what it will be, because money has to be paid for services rendered. Now, what I was driving at is, who owns the intellectual property to this system? Is it the country? And how is the process of technology transfer? Are we going to maintain these companies here? See, sometimes if it's your system as a country,
Yes.
it is yours. You don't have to have an outside person managing it. We have enough Kenyans who trained in IT, programmers, database managers, that can program and handle this system.
My
So the
sentiments,
technology
exactly.
transfer from Convergence, from Apero, well, Safaricom is local, they say, but from these other two, whatever they're having, it should be programmed in a way that they transfer the technology to the Kenyan people, to create jobs for the people, to continue having that system working for us, and we innovate and remodel it as we want, based on the principle that is still, as he said, open source. If it's open source, it's okay. If it's proprietary, as it's, maybe it's their own code. You see, there's a difference between open source and the other code. Own code is my own. That's why it has intellectual property rights. But if it's open source, it's free for everyone to use. So you cannot even really claim a lot of monies on it. It's not right in the principles of open source technology. But if it's theirs, they sell with full rights, they transfer technology, they train our technicians and IT programmers, and we inherit that. For the many years we'll be in Kenya, even for the children that will come after me. But to maintain these people after 10 years and even after another 10 years,
Still money.
and to say 10 years is the amount of time for us to understand this kind of coding, no, I did IT, but it doesn't look like that's how technology transfer should be. That's too long for you to transfer technology that's so important, crucial to a country.
Me, I'm
And
having...
you can't keep partners for some years and keep them on the background for advisory, but not as rent seekers.
But I'm having a hard time understanding the same government that is really talking about, creating employment for our youths, right? And they are so comfortable with exporting labor. So this is where my problem is. How come there are so many opportunities where our local people could get employment, but we seem to be giving this to foreign companies? And we still, are we undermining that our innovators cannot do
The
this?
same. That's true. We are undermining.
Hatuna wase wa
Do you know
IT.
why? We have claim processors in Kenya who have programmed systems that are used by the private sector, private health insurance sector in the country.
Wow.
You have companies like Smart, you have companies like Savannah Informatics, Synergy Informatics. These are like local coders, local programmers. The only challenge they probably have had, they've not been able to scale up because they've not been given that opportunity. But they can scale up programs that can work for our people. Just like we have e-citizen working, coded here and running under the Huduma program. It works. Now, but because you want to have rent and assured rent, you say Kenya doesn't have enough coders or programmers, so let's give it out. So that's a different principle on that end. So there's the issue of single sourcing and procurement and lucky contracts assurance and the programmers, the job creation market. There's the programs now of assuring people the right to access healthcare as per the constitution. So there are many things playing in and then bring in personal interests. And then our politicians in the parliament are not keen on this. And things just pass through them.
How can they be keen? We had a whole MP admitting that they did this so hurriedly.
So I've also heard that that system, the 5 billion system, is owned by someone here. And either because of conflict or something, they said they're taking too much rent. They're taking too much rent. The system was like 5B. Someone owns it in one of the politicians.
Yeah, NHIF.
Yes, the NHIF one. And because they don't like them or they're having their own wrangles, they want to oust them. and give it to another person so that you can roll. So that is what I've heard. That one is too funny, the system. Leave it, because that other person is gaming us. Let's pick another one and move. Now, even this other new one will also be in the same mix and same shades. So those are the kind of things that happen in the country. There will always be interests, but these interests must serve the common good. And it must be openly, transparently done. The contracts and public participation should have been done. The MP should have scrutinized whatever is being tendered so that we accept. If it's going by SHA, if it's going by Social Health Authority, or if they're going as partners into the system, they go on it. And then it's a property asset that's registered in the country and it's owned by the people of Kenya, not by foreigners. Here. Now we have another loophole, data management and data privacy.
Oh yes, I was going to ask.
Now these are people, well, they have their major companies maybe abroad. Data will flow. So our data will be analyzed elsewhere, will be processed elsewhere. Now, as you join in, there is that, when you join the SHA, you'll be told you accept, consent to this and that. You consent to data processing and handling, and whatever that will happen thereafter. And once you get in, your data is registered there permanently. But remember again, that the data law, you can always pull out or give conditions to how your data is managed. But that aspect of foreigners handling Kenyan data, they say it's stored here under the Safaricom cloud. But this cloud access is accessible by these other programmers from elsewhere, if they're not fully Kenyan programmers.
But
so data trading, data mining will happen elsewhere, and it will be profitable business for other people elsewhere. Those are different case matters. The dilemma here also comes, the data migration from NHIF to SHI. Remember when NHIF existed, if you did consent, you must give consent for your data handling as a person. This consent was to the data to be handled to the NHIF. You did not consent, or you did not even foresee that another agent will come to have your data taken out from where it was and be given to them for them to handle and process. So there's a little bit of an illegality there. Your consent has been overruled. Someone is going to pick up your data and move with it and tell you, now I have your data. You have not paid. Pay me. That's a 2.7%. Like, but I didn't register. I didn't give consent to have my data processed. Because the law as it is, it's deficient on the process of data transfer from that to this and how it's supposed to be handled. So the process of export, migration, transfer, not very clear. Now we are in the office of the data commissioner to advise if registration is optional and if the government has a duty to provide healthcare, does the government have a supreme or an absolute mandate to pick data from wherever because it belongs to you, put it in a system and demand of you to do particular things? You have a right as a person to opt in or opt out. See, those are questions that come in. So they say mandatory contribution. But what about mandatory registration? What about aspects of consent playing in the processing of data? So there's so many matters we could talk about SHI. So many. But all we want is that common good, UHC. And UHC that works, not UHC that is missold. It's like if you buy a life policy, someone tells you when you die, you will do this and that for your family. But you find out when you die, they'll only do one thing and not everything else. Then you end up complaining. So those are things that we seek to cure. These things that we're talking about is to correct and panel beat the system to work in favor of the many people. Because you want at least a basic cover for many things. That works without you going back into your pocket to buy elsewhere. So if it's hypertension, at least something substantial. If it's diabetes, something substantial. If it's cancer, something substantial. If it's dental, something substantial. Optic, something substantial. And then the top-ups for on the cases that you see that there's some things that are really costly and cannot be really programmed in the SHI law. Those ones you can always supplement outside
as you move.
Yes, but for the basic, provide it for the people. Don't sell too much and give very little. And then have a plan on how to resource the pools, the three fund pools. Because if they're running dry, you have no even courage to even say my people are assured of from out of pocket expending. The catastrophes will still happen because you told them that you're going to Mombasa, you reached halfway, you did not reach Mombasa. So you start struggling along the way. Mm-hmm. You have to rework the math. From the general taxes, money must go in to these funds for it to work. The same way education gets 650 or 600, healthcare, particularly financing. You see, let me give an analogy. Have a vehicle with two drivers, a driver from the county government and a driver from the national government. And you have one of the wheels being the healthcare finance module, and the other wheel being the human resource module, and the other wheel being the commodities, and the other wheel being the back wheel being the systems, the interconnectivity and digital management systems. So this vehicle has two drivers. They all have to have one vision where they're going. If one of them is thinking going the other way, it will not go. If one of them is disgruntled, they will keep on not helping. So the county government is acting like the shotgun to the national government driver.
Oh.
Now, the HR aspect, that's where we come in as a union, is not resourced well. Most of the facilities don't have enough doctors. Now you overpromise. Patients flood the hospitals. Workload goes up. What happens now? Patients start complaining that we're not satisfied because the doctors are not there, we're not happy.
They are not seeing us.
Yes, so the vehicle has to have all these modules moving in tandem. If this is not happening, the vehicle stalls, you start repairing, you'll never reach where you're going to that UHC. So HR important. Financing is where now we are focused. She is financing. Financing itself has its own issues moving in there. HR, its own issues. KEMSA and drugs and all the rest, its own issues. Systems, you have a PRO and the rest. See, each vehicle has like a small puncher somewhere. So, mambo ni mingi. So, you repair huko, and then move together. And then assurance of fuel to this car. If you have no fuel to this car, it will not move. That system will not work. Utakosa kulipa rent hiyo 104. Madawa, they have to be procured. HR, you start underpaying the doctors, they start frustrating the system. You start exploiting them, they start complaining. The workload becomes too much, they start complaining. So the interests must be met. Huku mbele, financing must work. You under resource, everyone who is supposed to enjoy the whole trip starts saying, we are not happy. We are not happy. So that common good vision implementation is a challenge. And we are all in this together. We speak up because we want to be heard, and we want our voices to be used to cure those small punches. You cure the HR issues, that is fixed. You cure financing huko, resource vizuri, there are no complaints there, it moves. Systems, do it locally, program vizuri, own your IP.
Good.
It's good. Huko nyuma kwingine, drugs, KEMSA, if they're having issues huko, fix it. Because again, now KEMSA has its own problems. They go buy drugs, I don't know, either expensively, they sell expensively, no one wants to buy from them. And then they start saying the counties are not paying.
Yes.
The counties also say the treasury is not giving them money. So you end up with dead stock, expired drugs, and a lot of games. So every time you go to the hospitals, there are no supplies. So when there are no supplies, the service is not complete. Because I'll treat you as a doctor and I'll tell you, go to a nearby pharmacy, buy me, like now I'm supposed to go to theater, like they don't have, there are drugs that they use to make you sleep, isoflurane and sevoflurane. They say they're missing. So that means I either have to use halothane, which is substandard for, if you want to have good outcomes, the drugs you should use. But not because things are so bad, that is what is available. The good one is not stocked, and if it's stocked, it's very costly. And they start saying, if KEMSA does not stock, we will have to follow a process, like a bureaucratic process for you to buy it elsewhere. So it becomes so bad that patients now have to buy them, those drugs. The machines are not serviced. The other day we did the equipment financing with the MES program. That was good. It did help. Now, if we don't keep on sustaining that principle, the machines break down because there's wear and tear. Not all users are careful with the machines, and because we are Kenyans, we break parts. So mtu anavuta machine huko inavunjika, mwingine anagonganisha na huko. It requires repair. The program, the softwares get outdated sometimes. The backups get loaded. It requires regular maintenance, and there's money to be paid. If that doesn't happen, you'll go for that CT scan. You'll be told today the machine is down, end up private. And if the persons in the public sector are not motivated to continue doing the things, that means, you see, in private, you have to always optimize your systems for you to get money. So the other picture could be a commercialization of healthcare, whereby the system works good, but because of lack of leadership and lack of interest by the county governors
and integrity,
they sabotage the system. There are many players in there. They also want into their own things. Everyone wants to run their own show outside, and outside it works. So they start eating from outside, and eating outside is expensive. than eating where it is publicly funded. So if you wanted a public healthcare system to work, we have to all be guardians of that system. Saizi unasikia wanasema MPs will have private insurance. Judges have private insurance. County governments and their employees will also have private insurance. Who else? Everyone who is somewhere in the parastatals or the public service will have a private insurance. Because it is good to supplement what you don't have. It is good. Well, I'll speak in that principle. I hope you pick what I'm saying.
I'm picking.
Yes.
I'm picking.
It is good to supplement with private insurance.
Hey.
And it is good to still collect for the public insurance. So when you collect for public insurance, collect for public, you're having two competing interests and fragmentation in a way. So you don't have adequacy. So when you don't have adequacy, you keep running, but you say this adequacy is for those poor people. Even those poor people, they will still have complaints.
So, Daktari, simple question. So why can't Shif be mandatory? Why can't we, now do away with private insurance and make Shif mandatory for our public service so that kama we ni judge, please tumia Shif, go to Kenyatta National Hospital, get treated, get out, experience, see what people
so
go
that it
through.
works for all of us.
So that it works for all of us.
Well, there have been talks for that. And I don't know. People don't have trust. We don't have trust. They don't believe there are good doctors in the country. Kenya is actually like number 3 or number 2 in Africa with the best healthcare services. Yes. Well-trained doctors. And even as per the Vision 2030, we are supposed to have medical tourism like India or like South Africa or like Turkey, whereby you have now Kenya leading in Africa or in East Africa as the best point to access healthcare. Yes, we do have Tanzanians, you have Rwandans coming in here and they enjoy what we provide. They come to Nairobi Hospital, but I haven't seen the Tanzanians come to, let's say which one? Like Mama Lucy.
Yes.
And access the services at Mama Lucy.
Yeah.
But that is where we should be. Make Mama Lucy attractive to the Rwandans, to the Burundians, because they believe Mama Lucy has the best machines. But I hear they go to KU.
Of course.
For the cyber knife and all the rest. Services are available. But as Kenyans, we have to believe in what we have. Hii kwenda abroad zote na kununua covers expensive because they can export you out.
Sasa sisi tuende wapi? Watu hapa
sisi tutaenda hapa.
Nasema, I saw a former CS also advocating for Shif. And I remember when he had a leg injury, he went to Dubai.
Oh, yeah.
But you are here telling people how Shif is good. But you, when something happens to you ship out and you go to Dubai. The irony.
Yeah, I'm also trying to rethink the fact. You've seen the pay slip of one of the MPs. Yes. You've seen that?
Yes.
What did you see? How much was left as net when you saw the last pay slip? Or who remembers the amount that was left on the pay slip?
Niliona ya mwenye ako na loan.
2,000 was left. 2,000. No. Now huyo mtu hata ukimwekea Shif, what will Shif bite? You see, they're strategic because this is a pay slip. It has this less left. Then introduce Shif. Am I threatened? There is nothing for Shif to eat, because it's probably been locked elsewhere. Now it will be Shif with other funds fighting. You have a mortgage to the property, to your properties and all that. You have a loan, you have a SACCO. All money is committed. Now Shif says 2.7% of your gross will go to Shif. But where? If it's in the payslip, where? You'll squeeze what? You'll have to either restructure your mortgage and your loans and your SACCOs to give an allowance for Shif. Then you also have another principle of the 2/3 1/3 rule. How much will remain in your payslip? Or even in breach of that as per the Employment Act. So some people are shielded from the Shif. The rest are not shielded because the laws that apply to them are different from the others. That you all serve the same laws. So that's why you find some people will complain much, others will not complain much. And yet it's supposed to be a solidarity principle. We pull money to one fund for us to benefit. But some are producing more than others. And if you produce more for many years and others are not, you will rebel.
And I'm also seeing a conflict because now the employed will start saying, why should I provide for...
For now, it looks like a fight for the employed.
No, it's a
but
fight.
It will still also be a fight for the informally employed because once they do the means testing, they'll also demand. And they'll wonder, why am I paying this much and I never get anything from here?
Yeah.
So if it's free, like it was in the Kibaki era on the free primary education, let it be so free.
Free.
And the president is on record several times, utaenda hospitali, utatibiwa for free. Which is a principle of UHC. For free, no top-ups.
Anyways.
But not money is given. So a promise now unanyima.
Ni unafanya.
You're doing something that's not right.
Yeah.
Promise, give the money, prioritize the sector.
Hey.
All the issues of that vehicle must be in harmony.
People are over-promising here and under-deliver.
Yes,
But bottom up, here we come.
Well, tunang'ang'ana tu.
Tunang'ang'ana tu. Shukran.
Thank you.
I know people have picked a thing or two. I think we've all understood. And also, I think Kenyans are really aware of what's happening. But there's a propaganda by people to say, you know, Kenyans don't understand these things.
Well, no. Kenyans sasa wamekuwa
Kenyans
wamerefuka wengi sana wanaelewa mambo.
Wanaelewa mambo.
Because I share a law.
Yeah.
They read. They even interpret it for me. Mpaka wasema, we are now like, I'm a lawyer, but you're also learning the tricks of lawyering, and you can read because the laws are in English, plain English. Law is not complex, and all Kenyans should embrace the law. Take time to just go. Everything Kenyan that is law is on the internet. Kenya Law website. Download whatever thing you want to read. Read, scrutinize the pen and paper. Then now go to the context.
Yes.
And become a better citizen. We cannot change the country if you're all afraid of learning the law.
No, we cannot.
It cannot.
We cannot.
Tuna kazi.
Yes.
So don't fear ati lawyer anaongea kizungu kubwa kubwa nini. Hiyo ni kizungu tu, like a little brag. But the concept is the same. Logic. I want this and this. I say give them that. If that doesn't happen, query the law. Yes.
Query. But thank you so much, Daktari. It's been really amazing having you on the show. And I can't wait to see the feedback by our people who, you know, people who are going to watch this. But other than that, what would be your parting shot and how can people connect with you?
Okay, well, thank you. Mine is for us to be good citizens and to prioritize our common good and to try and see whether we can always check for conflicts of interest in whatever we do. Because if this conflict of interest keeps on to eat into our public resources, we are not going anywhere. We keep on saying we borrowed loans, they disappeared. We bought a system, the monies have disappeared. Someone is overpaying for rent for a particular system, it's disappearing. And if something is promised to us as a people in the Constitution, we all must aspire to it. And again, align with the global position of where we're going and safeguard our resources. Because without all this, we'll always complain. We'll always complain. So be watchful for corruption. Because this corruption thing, it's a big monster. I even see newspapers from 1963. They still have, we are going to weed out corruption. You have a news page with a proper big headline, 1964, 1965. So the monster has been with us for many years. And it's time, as we mature into a proper democracy, we're able to call out wrong and push for the laws to work for us. We're here. So, and as much as the laws evolve, they must evolve in good principle to assure the people of the country what is supposed to be done right.
Yeah.
No one should spend money out of pocket. No one should spend money out of pocket on basic coverage of care. So the cover should be substantial. Only thing, if I want a liposuction, or if I want a hair transplant, or I want my eyelids or something adjusted, those are extras. Those extras should not be covered. That is in principle to the majority. But the basics of bed admissions, surgeries to a particular limit, that should be there. But if you let issues simmer, that means then nothing is working. We're just into re-engineering, rebranding, and there's money in that. T-shirts, roadshows, banners, brochures. We are happy to produce that, and we produce that in plenty. But the spirit of delivery, the vision from the leadership to the implementers and to the people, we are the shareholders as Kenyans. I have heard the other day, one of us, he's being whipped this week. They say they're the shareholders. No. We as citizens are the shareholders. They are our board representations. And we have a CEO. Now, if the board and the CEO, they are misbehaving, we as shareholders, the citizens who own the right to speak with our votes, we call them out. And as shareholders, what do shareholders do? We do a shareholders meeting, we call management into question, chase them by our shareholder right.
Yes.
Otherwise, the game of we are the shareholders, you are not, you're observers, the spectators, that is mischief.
That's mischief.
Stand out, call out mischief.
But then you've reminded me something. Does she have its own employees? Because I read somewhere they are now going to ship NHIF employees to
the other side.
To the other side. What does the law say? I thought hiring is competent.
The project is so visionary.
Hey.
But now the technicalities of these small things, they were not well thought out.
Anyway.
So they said, we're going to forgo the old bad system. It's a very, let's call it a very witchcrafty or monstrosity kind of a system. Leave it, forget it, move. And that's how we should reform Kenya. Leave the old ways, go to the new ways. Ideally, that should work. But now we find that it's not possible. Because their interests, the employees and the employment law protects them against redundancies arbitrarily.
Yes.
And their cost redundancies. And if you inherit liabilities, you will spend good money to pay liabilities for long. Each employee is supposed to be paid about that ratio of redundancy payout if you're going to fire them. And then the cost of hiring, the cost of interviews, cost of getting the best talent, it's complex. It's not easy. So that's why yesterday or the other day we are not going to chase you as a former employee, let's say former employees of NHIF. We're going to move with you to Tahama na nyinyi. That's why you're moving with the same people on the basis that it's too costly to do redundancy, it's too costly to do hiring, it's too costly to get the best talent. So you move with them.
Yes.
So in principle, then it looks like all these things could still have been done without rebranding. Now, the knowledge gap between those who knew NHIF and those who know Shif, it's too huge, it's too steep. You have to do a lot of civic education. That is money spending. Now, this money that is used to publicize should have been used to just improve. And weed out the funny persons in the system. If PHC was supposed to be, ungeweka PHC as a section in the NHIF Act. Emergency fund, because it's a good thing, ungeweka tu under NHIF fund. Or even outside NHIF fund, because it's a program that's assured by the Constitution. You can even put it under the Health Act. Or even put it as under a program under the National Treasury somewhere, as a fund, and assure Kenyans of that. And then work out to weed out the funny people.
Yes.
Toa corruption kidogo, improve the systems, develop the modules that you want on this system, add them ukisonga. Progressive growth. But now they say, drop the system, assemble a new one. Move with the people, new systems, new logos, new cars. Only the office is the same one. I don't know, maybe they should relocate.
Yes.
So that we forget the spirit of
NHIF.
But it is doable.
Yes.
So where we are stuck at education and understanding.
But the people...
And the incongruence of the benefits that are supposed to come.
The employees you are moving with. See, I thought NHIF was corrupt. But then do we have any of these corrupt people being prosecuted?
If you have done research, problem justification, project justification, research justification. So you have to imagine and perceive and believe in those problems. The problems are corruption. The problems are failed systems. The problems are a working inefficient system. And now you sort out to fix them. But now you realize, I still need those problems. So those problems, as much as I call them problems for me to settle on the project, I need them as I want to go. Sometimes there is that organic growth, which is a journey that we've traveled since 1966 when NHIF came in. But we forget that and say, it's new. Well, new is good all the time.
And all the time.
Yeah. So,
but in the corridors of justice, do we have anyone being prosecuted for the NHIF
corrupt case? I haven't seen. So that's why it becomes a little bit mischievous.
Where?
The Senate did a record the other day, a report, and they have flagged how much was spent, which particular programs were too expensive, and what needed to be done. And they have advised the AG or the DPP to move to prosecute some of those matters and follow up on those people. Now they also fight with the law. I was not corrupt because patients came to me and I treated them. And because I'm a busy facility, I see as many people as they come. So what money have I stolen? So that's their defense most of the time. So it becomes a little bit tricky on how to prosecute some of these cases because it's not direct fraud like you'd see. See, claim processing is a funny game. You come to a facility, you fill a form, or your fingerprints are taken, and you are validated that it is you, and you have this particular service, and you're supposed to have 5,000 going into your cover. And then once you consume the service, that is approved. And that 5,000 is supposed to be paid to the owner of the service provider. Now, when so many incidences happen, you end up overpaying a particular person. Now, assume this is a tap. There are particular taps you open to flow more than others. So taps that are allowed to flow more are the well-connected taps. Understand that? Owners or persons with interests in that particular system, they have their taps open in a floodgate. The other, their taps are squeezed. That's why you get public sector getting squeezed. That's why you used to hear that time of clinics, you used to get a lot of money than even NHIF. That clinics are doing a lot of work than KNH. It was absurd. And clinics came and went. Same spirits. Now these same spirits will again re-evolve, likely, and join into this new system of Shif. And the taps will be opened again to those same connected persons. And some people will be strangulated in the system and they'll get frustrated. Now, woe unto you if you're a Kenyan. You go to a system that is choked. You'll go to the other side because it's like herding, it's shepherding. Everyone is trying to control. It's uncompetitive trade practices. You slow down payments on this side. You increase the frequency of payments on this side. The business on this side booms. If you're a client who visits that facility, you get frustrated. You're attracted to the other side. So the business interest of its owners keeps on growing. So the equity of providers and the fair competition is not really assured in this particular system. And more so when you have big players in the private sector, being co-owners or co-drivers or pro-campaign regime adversaries. Because now these ones, they're the drivers now. They're the big fish. They stay on the top of the map. They see, they control how the game should play. It has happened in other countries. It happened in the US. It happens in India. It happens in Canada. It is happening here. It has happened in South Africa. So the big players know how to play. They invest during campaigns.
And it's time
and
to
since
collect.
Our investment is never hard. It's only our sweat that keeps on to wash us. It's not okay.
Unfortunately.
So we must stand and speak until we are heard. And collectively, when our voice becomes louder, we fire the management.
Good.
Yes.
Because this is our country.
Yes. There is nowhere else to go.
Yeah.
So we can't go fix India. Can't go fix South Africa.
Kenya
you are
is
here.
home.
So your blood is here. So fanya vitu zako hapa.
How can people connect with you?
Well, mimi I'm all over the place.
Yes.
So I meet with my patients, like
Yeah.
I'm going right now. I'll be in theater, fixing my cases. I do medical legal cases, I do different matters hapa na pale. And we have to keep on educating.
Yeah.
So go to the internet, find whatever we've written about, read, comprehend, critique it, because without that critique, I will not improve my thought process. And my thought process is informed by the case studies of what has been studied in other countries. All these projects that we're doing, they've been done elsewhere. Housing, Singapore. Healthcare, Singapore. Healthcare, Thailand. Healthcare, England. Healthcare, German.
Huduma number?
Huduma number.
What
it's
happened
also
to, anyway,
Huduma
I
number and
think
Maisha
I'll
number
ask
in
that
France,
next time.
and fingerprints and all that. So these are not new projects. People have studied these programs. And the loopholes, the weaknesses of these systems are studied. And our drivers of this project, they say they're guided by these papers. You see, this is like science and project management. They're guided by these papers. We are equally guided by those papers, plus the other papers in conflict or in contradiction of the same. But we have to have a common position. You can't say that paper doesn't say the truth, that paper says the truth, and you believe in it. So we try and build up by as many challenges as you pick from the experiences of other people. We all want the best. Where it is working, move with it. German is working. UK, they are struggling because of underfunding. Singapore is working because most people the government has tried to cushion them. Thailand, it's working because they have different models for different interests. So here we want to pull everyone into one interest. No? People have different specialities and peculiarities. Pick them as they are. Cushion them as they are.
Yeah.
Usiwa expose and mix margin, sema it's one pot, go. Ukichanganisha vitu haziingiani, the food doesn't taste nice. Yes. It has to be properly made. Make a pot of rice, uku serve. Then it's a full serving, everyone is happy. Mix mash everything in one pot.
Ew.
You're likely not to be where you wanted. You'll have indigestion.
And I think one of the problems I'm experiencing with this whole Shif thing is they're not telling us how they'll deal with the corruption that we experienced in NHIF. It's assured. A lot of talk. We are being ensured.
Corruption, you wait until the claims get to be paid. For now, I have heard that they want to pay after the quarter. You see, before NHIF was paying before the quarter. So I give you money, capitation, you run your programs. Now I'll tell you, run the programs, I'll pay you after. So if I pay you after and you incur costs and then you delay paying me, I get frustrated. If I get frustrated, next time I don't want to
work, associate.
That means patients will be disgruntled. And that disgruntlement is what we want to cure. You see, UHC cures that spend. But that spend has so many things happening around it. If you don't fix them, you introduce conflicts into delivering UHC. So we must be alive to the dynamics of the transactions.
All right. Shukran, let me let you go. I know you definitely have a tight schedule ahead of you, but again, I appreciate you making time this morning to be able to just come and talk to us about this whole thing. And I know right now anyone who has watched is well informed. So
yes, they are well, and we have to keep on doing civic education.
Yes, it's a must.
Lazima, hakuna choice.
All the best.
Thank you.
And also to you guys who are watching at home personally, I know you can be able to connect with Daktari here on X. He's very vocal there, so check him out. The details are on the screen. And also, I'm really interested in your feedback on this. Remember, we've said our intention with this show is to make sure that we continue just give, just having civic education the best way we know how. Because when we say Kenya ni home, we all have a collective responsibility. And you remember one day, I remember we sat here with Dr. Wandia Njoya and we were talking about CBC. And I would encourage you to go watch that episode if you've not watched. And she said something. And when I was having a conversation with this professor in USIU, I asked him, let me ask you, why do we have CBC? Do you think CBC is going to work in this country? And he laughed and said, Lynn, sometimes it's never about the people, it's about the regime and what they want to leave behind. So they don't care how it's being done, it must be done. But we're in an era where it shouldn't be done if it's not right by the citizens. So thank you so much. Support our work, guys, by subscribing. We also have an M-Pesa number that you can be able to use to support independent journalism. And also to everyone that is playing their role in civic education, we appreciate you. Thank you to the incredible team that puts this work together. I've said over and over, you get to see me in front of the camera, but it takes an entire team to put this together. So shukran sana. How about I see you tomorrow? You know the time, 10 a.m. or 7 p.m. Bye-bye.